I was talking about womb transplantation, and effectively we've got a 20-year programme of research which is almost about to come to fruition. So we, in the autumn, certainly the back end of this year, hope to do 3 live donor uterine transplants and to start a process whereby we're going to do 10 DBD, which is brain dead donor transplants, where the donors obviously are heart-beating cadaveric donations from intensive care type setting. The live donor cases are going to be where the donors, in fact the first 3 women who we have got teed up, it's 2 mothers and daughters and 1 sister and sister. So the sister's completed her family donating her uterus to the sister who hasn't got a uterus. And principally, although the subject of the talk was uterine transplantation in endometrial cancer, in fact there are very few people who've approached us who've had endometrial cancer, and the majority of women who've approached us looking to have a transplanted uterus are women who've got Mayer Rokitansky Küster Hauser syndrome, so they were born without a uterus. They've usually got a vagina and they've got ovaries, but there's no womb. And so that's 90% of the people who've approached us looking for a womb transplant. 10% of the people who've approached us had an oncological diagnosis and they've had a hysterectomy, mostly because of cervix cancer. And if you look at so there've been 42 uterine transplants in the world so far, and of those there's 1 woman who had cervical. There's only 1 woman who had a cancer diagnosis. The rest are mostly Mayer Rokitansky. 21 years ago was when we started this, and it started with a procedure called abdominal radical trachelectomy, which is a fertility sparing procedure for cervix cancer. And during that operation, if it's done open, got patients who have them open, and the uterus is actually out, attached to the aorta via the ovarian vessels, and you cut the cervix cancer off and then stitch it back in. And it was kind of on the back of that that the idea that perhaps we could transplant uteruses came about. And one of my great friends, a guy called Sam Abdallah, who's the director of Lister Fertility Clinic in Chelsea. She's the country's biggest IVF clinic. And he and I have worked together since the early 80s. And he and I sat together, and he said it's the one group of women that as a fertility specialist we can't treat is women who don't have a uterus. There's surrogacy, there's adoption, but that's it. And that was the kind of genesis of the idea, and we've gone down multiple dead-end routes. So we started off using small vessel anastomosis, and that doesn't work. And the first human uterine transplant was in 2000, and it failed, and it was done using small vessels. And the woman, the recipient, got microvascular thrombosis of her uterus 3 months out, and her uterus had to be removed. We had exactly the same results in a series. We'd worked in the porcine model, and we'd actually had the same results in our pig model. We then, it's a long time ago, 18 years ago, we went to Nadi Hakim, who's professor of transplant surgery at St Mary's at the time, and he said you should use a large vessel patch technique. And we did a series of work where we showed that if you remove the uterus with the uterine vessels and the internal iliac arteries and veins as your en bloc graft, and in fact we did actually originally also bring out the aorta and the inferior vena cava. You can put a Venflon into the aorta or cannula, open it, and 10 minutes later you've got clear fluid flowing out the inferior vena cava, no leakage, and a white uterus because all the blood's gone. And that became the model which in fact the Swedish group, who got way ahead of us and delivered their first baby in 2014, but they used a large vessel patch technique to do their transplants. And we, as of 2014, we'd got to the point where we had, it's quite interesting, we had 70 peer-reviewed publications, and the Swedes went for ethics when they'd got 70 publications, and that's when we felt comfortable that we'd done quite a lot of animal work, and we'd had 3rd pregnancy in the world in an animal model where the uterus had been transplanted, and we felt it was time for us to go kind of live into a human setting. And we got National Ethics Committee approval in 2015, but because we were looking not to do live donors at that time, but to only do brain dead donors, we've then and rightly got into the huge regulatory process that goes with NHS blood and transplantation, because we mustn't do anything to besmirch the reputation of NHSBT in any way to do with vital organ donation. So heart, lungs, liver, kidneys, pancreas, now small bowels, various things being transplanted. And so we've been through that regulatory process, which effectively taken us about 2 years. And we've been to multiple meetings. And then, ironically, having got full approval to run a research project to do 10 DBDs, transplants, brain dead donor transplants, November last year, so November 17, Lisa Johansson, who used to work with Mats Brandstrom in Sweden, where the first series was done, Lisa moved to Dallas, and they utilised a new retrieval technique in their live donors. So the Brandstrom technique is to have an internal iliac artery and vein as the main patch, but that means that the retrieval operations were lasting between 10 and 13 hours, and they had one ureteric injury because the ureter's running, the uterine veins run above and below the ureter sometimes, and so it was a very long retrieval process, and we were there's nothing ethically wrong with it, but somebody's going to get, in that length of retrieval, somebody's going to get a deep venous thrombosis to pulmonary embolism, just because the operations are way over 6 hours. So we said we wouldn't do it. Lisa Johansson gave a presentation, new technique, you can do the retrieval in 3 hours. And there is a vast irony, because so the new graft is the uterine artery, internal iliac artery, but the venous drainage is not through the uterine veins at all, it comes up the ovarian veins. And the irony is that that's the original trachelectomy technique, right? So in the trachelectomy, the uterus is supplied the arterial blood goes down the ovarian vessel and it comes back up the ovarian vessel. So suddenly we're actually doing the retrieval that it's where the whole thing started. But the whole team, none of us can believe it, because it's like, how stupid are we, right? It was actually, we originally described trachelectomy and we never saw that was actually going to be the retrieval method. So on the back of that, we know we can retrieve in 3 hours. So we're now about to do live donors. I suspect that when it comes to DBD, we know through the specialist nurses organisation and all the data that exists that there will only be across London South East, which is effectively a 20 million conurbation, there'll be 10 appropriate uteruses per annum. And if you want my guess, there'll be another centre in the north, somewhere, kind of that Liverpool, Manchester, Leeds, Newcastle swathe, where there's another 20 million conurbation, and that there'll be a centre in each doing DBDs at the rate of probably one a month, because that's the entirety of the organs that are available for DBD. When it comes to the live donation aspect, and that's at the moment all the babies born worldwide have all come from live donation uteruses. There are no DBD uteruses that have produced a baby yet, but that's partly because there's only 9 that have been done DBD, and they've been done much more recently. With the live donation, that's something I suspect that may end up being done maybe in a couple of places in London, somewhere, maybe a couple of places in the north. I'm guessing a few more, but there are issues around funding. So we've applied and registered with NHS England to have funding for a national DBD uterine transplant centre, perhaps to open in about 4 years' time when we've completed that research project and produced babies. The live donor procedure is not a research procedure anymore because it is established and plenty of babies have been born. But how the funding for that would work is not clear yet, and that's not what we've put into NHS England at this point. But I suspect we may well do that later. Live donation, uterine transplantation, is an established procedure. It is highly successful. The fertility rates are really high. Astoundingly high. In the Swedish group, the fertility rate so they planned to do 10 transplants. They did 9. 1 got sepsis at 3 months, uterus out. 1 got thrombosis. 7 left. Of those 7, 6 have had 1 or more babies, and the 7th woman has had multiple pregnancies, which sadly have miscarried. But she is a woman who's got a neo-vagina, and that may have upset the microbiome. So this is and that was the first series. And since then there are multiple, there are more babies. And so that, to my mind, is an established technique. The DBD, our research project, should show in a viable way whether this is a viable procedure which has got a long-term future, and we'll know that within 2 years. And there's no reason why it shouldn't work at all. With all the preliminary work, everything around this suggests that it will. So I suppose the concluding message is this is very close to happening in the UK, and there's very good prospects that it's going to work. But really important to say the number of women who are likely to want to access it is actually relatively small.